Hope everyone enjoyed their lunch. We're going to roll right into our health forum right now. We are indebted to my distinguished predecessor, Chairman Emeritus George D. Barrett, for initiating and organizing a panel called Health and Wellness, Improving Our Quality of Life. I think you will agree that there could be no more important topic, along with our spiritual health, which we are continually learning go hand in hand. George has invited two prominent physicians to join him in this discussion, Dr. George Dangas and Dr. Harry Anastopoulos. George will properly introduce our distinguished panel, but I would like to take a moment to say a few words about our former chairman. He is a pioneer in the pharmaceutical industry and is a world-renowned philanthropist who is dedicated to improving lives. George has funded numerous programs at top medical schools across the country and has devoted himself to working with Harvard University, the Hellenic Cancer Society of Greece, and his cousin, Dr. Panagiotis Barakis, a prominent pulmonary specialist in Greece, toward an anti-smoking campaign known as Smoke-Free Greece. This program has been credited with significantly reducing smoking among Greece youth. The number I have here is roughly 32% in 2018. So it is my pleasure to present you our beloved former chairman, George Barakis.
Thank you, Mr. Chairman. This is a very exciting topic for all of us, and I hope you enjoy it, because the two distinguished physicians are going to tell us how to live our lives. This afternoon, it's a great honor and privilege to lead a discussion on a topic of critical importance to all of us. The one has always been a great interest to me because in my professional career in the pharmaceutical business, my goal was to try to develop pharmaceuticals in health to improve our quality of life. For this purpose, I have been pleased that two prominent physicians have agreed to join us this afternoon. Before making some great general remarks on the topics to be discussed, allow me to introduce them. First, George Dangas, MD, PhD, Professor of Medicine, Cardiology, Professor of Surgery at the Icahn School of Medicine at Mount Sinai Medical Center in New York City, a leading authority in interventional cardiology. I learned just maybe a week ago through some friends that Dr. Dangas, it should be noted, has been voted the recipient of one of the highest awards in medicine by the American College of Cardiology. He will receive the Distinguished Fellow Award in recognition of his service to the college and as a role model for others. He will be honored at the American College of Cardiology in March, I think it's March 18th in New Orleans, Louisiana. Dr. Dangas, a heartfelt congratulations to you. Harry T. Anastopoulos, MD, is a gastroenterologist and a clinical instructor in medicine at Harvard Medical School, and he is affiliated with the Beth Israel Deaconess Hospital Medical Center in Boston, Massachusetts. Thank you for coming, Dr. Anastopoulos. You know, in my career in the pharmaceutical business, I get closely associated with many physicians and medical and scientific research, including my own. And I focused on one particular area. First was eye doctor, ophthalmology, making drugs. And then my focus was on asthma and allergy, because that was my original career. So I made sure I went in something that I wanted to know. Now, our distinguished chairman mentioned about the cancer Hellenic Cancer Society that I'm involved with the Harvard School of Public Health, where we send physicians over to talk to young people in Greece from the 11 to 17 years old. And you're going to hear about it from physicians here about smoking and what can happen, what nicotine does to the system. And we've been very successful over the past 8 years to really cut, as our chairman mentioned, 32% in 2018, which is, and the young people of Greece are very bright, very intelligent. I go every November, and we spent about 10 days talking to possibly 8,000 young people. And I can tell you they're very bright and very intelligent, and they all want to come to school here in America, which is very encouraging. So for the past 10 years, the Center of Disease Control and Prevention, called CDC, has been collecting and examining data. This information helps researchers and doctors understand if they need to address growing epidemics in healthcare reported in Healthline. The number is really to prevent measures that may help people to live longer and healthier lives. The top 12 causes of death in the United States account for 75% of all deaths. The 12 leading causes of death in the United States are heart disease, cancer, accidents, chronic lower respiratory disease, stroke, Alzheimer's disease, diabetes, influenza, pneumonia, kidney disease, suicide, septicemia, and liver disease. The leading cause of death worldwide is similar to the United States. But in the U.S., we've made great strides in the past decade, especially in the area of heart disease and cancer. And if we combine this with the most interesting statistic in the United States, while we present or prevent early death, we can do a lot of power in ourselves by helping as a family, because the leading cause is really lifestyle changes that we need to accomplish as we get older. The word is compliance. A lot of people do not comply with what the physician tells them to do, and they see the physician once they get sick. And the other non-compliance, and I did research on this and wrote a paper in the pharmaceutical journals, as I went around to the major chain stores and talked to CVS and Walgreens, who are my customers, Walmart. 53% of the patients do not refill their prescriptions on time. And now it's all documented. And what's happened is that the patients come into the pharmacy and they haven't taken a drug for 5 days, 10 days, and they ask, why aren't you taking it? You should have refilled this 2 weeks ago. Well, I feel terrific, but now I don't feel good. Why don't you go see the doctor? Well, I'm afraid to see him. So basically at this time, I'm going to ask the physicians, I'm going to ask Dr. Dangus to come up and give some remarks about what he has seen in his career in healthcare. Dr. Dangus?
Great. Thank you very much, Dr. Barakis, for this great introduction, and your eminence and great participants. Thank you for your coming to attend this lecture that was graciously invited me to give you. And turns out that I'm not going to give a classic lecture, but more a little bit of a show and tell and encourage some discussions, and we see some things we can do about lifestyle and other management. Let's focus in general about cardiovascular, and you can see a pictorial of the different things that can happen and hopefully will not happen if we do all of us, some very simple things. The cardiovascular system is just as pretty much like the boiler and the heating system in in any house. Includes a pump and many vessels like the hot water, the cold water, the veins and the arteries, blue and red blood, so to speak. They circulate all over, and they may get clogged. They may get clogged at any spot. If this gets clogged in the heart itself, that's a heart attack. If it gets clogged up in the brain, it's a stroke. If it gets clogged down in the legs, well, it's a leg emboli, so to speak. And also they may also dilate, they may balloon, they may break. That's what we can call aortic disease. So in general, the epidemiology is that for the first time, the last 10 years or so, looks like this whole disease is a little bit on a decline, which is a good thing. So let's go to the different things. And this is a boring slide we're not going to have anymore, but you can see on the left it's a very, very clearly and with parameters listed the smoking issues, the weight issues, the body mass index, so to speak, that's a scientific terminology, the activity issues, the health diet, the cholesterol, the blood pressure, the sugar. And all things everyone should sort of know, and thank God for these little devices all have, the so-called smartphones. They can help us in a lot of things about a lot of these situations, just if we just play with some of the apps they allow. The important thing I want to point right now here is that the physical activity, we really need to pay some attention on a very, I would say, misnomer is that, okay, well, we missed 3 days or whatever, we missed a week, let's go exercise 5 hours. That's actually bad. Actually, the opposite we should be doing. You try to, in the physical exercise and many other things, in prevention and lifestyle care, you want to fit something in your schedule, something that you like in your schedule, in a way that you like it and that it also fits regularly. We don't want to say, you know, otherwise you may have a heart attack, for example, during exercise. You may have heard those possibilities as well. So you have to be regular in all of those things. And that's why there's so many possibilities, because people like different things. And unless you like what you do, number one, you're not going to follow it. That's less compliance. Or you're going to be unhappy while you're doing it. That again doesn't help, because the brain, when you're unhappy, sends messages with substances all over the body that sort of negate any benefit you may have otherwise. So we've got to be very careful about that. And one of the, I already said, and probably all of you know that, you know, you can measure in the iPhones and the other smartphones how many steps you did. It was up, it was down, how your heart rate, your blood pressure perhaps. Now they say you're going to just hold it in your hand. It's going to show you an EKG and all that. It's probably people navigated it. Somewhere there is actually a risk calculator. You can you know, download and play with it. It's the American College of Cardiology risk calculator, and puts very simple parameters. If you look at every simple parameter put here, it's actually very easy. Age, gender, race, cholesterol, there's all these numbers. People sort of know these numbers. And then you calculate, and this is how we do, and we teach our students to do that. It's very easy. It is directed to the public, and there are many others as well, but obviously the college ones is more associated with the specific numbers of how well you do further in life according to all of those. Let's talk about age and gender. First of all, you can see that there is always a little bit of a lower prevalence of cardiovascular disease in women. This is because of the generally protective effect of women, gynecological hormones in women. Let me just make clear that, because now with the administration of these hormones perhaps in men or other situations, these protective effects are not really there. So not really the hormones, it's the hormones in women that sort of help prevent or mitigate, I would say. At the same time, this slide also shows that over time, the blood vessels will suffer from wear and tear. So, you know, as everybody knows, the heating system and the plumbing system of the house need some upgrades here and there. Why? Because over time, there is wear and tear as well. So we can all imagine about that. Also, we know that the ultimate I would say, parameter about the epidemiology of any kind of disease is that in the end, as we all very well know, and particularly in the context of these spiritual meetings, that nobody survived, and thus far only one has been able to come back in exactly 2019 years ago. So in the end of the day, wear and tear will prevail, but we can do the most we can by preventive measures to push that date further down. Now, cholesterol is all these little sticky things that may be affecting how the blood flows. It is our responsibility to not allow it to accumulate. The body in general doesn't have a good way to get rid of cholesterol. Most substances we eat, the body, a lot of whatever we eat in sugars, this, that, the other, has ways to make it go away. There is a lot of inefficiency getting rid of cholesterol. That's why the body needs a lot of help with a diet and other measures in order to avoid too much cholesterol flood. Because if that occurs, then the body cannot, the human organism cannot really get rid of cholesterol very well. And the ideal cholesterol is the cholesterol everybody has in childhood. And it just keeps going up slowly during all our life. And this is just a fact that we all realize the last decade or so. There is no bottom number. Kids have a bad cholesterol level is maybe 20. And adults, if people check the cholesterol, they're going to be between 100 and 200. So you see how much way down we go. We used to want to be less than 100, we went to less than 70. We keep going lower and lower, and the lower the better. The smoking is a big one, and we cannot do it to ourselves. And being Greeks, we know what it means. We feel it every time we visit our friends and families down in Greece. It's abundant all over the place. It's a culture, I would say, so that's why a society has to do the best in order to get rid of that. It has a lot of problems, not only in the cardiovascular system with the hardening of the arteries. The pipes become non-distensible, they're very hard. The valves become very hard. And also the lungs are pretty bad. And you heard that also there's all sorts of other rare cancers can start becoming a little bit higher rate because of the toxic effects of smoking. So the major lifestyle decision for someone is to just stop. And there are many medications that can help in this decision. But unless there's a firm decision made by the person, those are not going to work on their own. It cannot be that I'm not motivated and somehow I believe that a pill a day of whatever may be is going to work. No, it will not. There has to be a firm decision, a firm date, and if the initial attempt is not so successful, there are one or two ways to help with supervised medical therapy by your primary care doctor. The high blood sugar and diabetes, another thing that is very abundant perhaps, is becoming much more abundant in the United States this time because of the abundance of food and abundance of fast food in this country. And the obesity epidemic, as we call it, is going to have a secondary diabetic epidemic. And the next target after the United States, believe it or not, is going to be China, because they have a lot of similar eating habits building up with all the changes in that society. And obviously they're huge, and as I said, these kind of things are very cultural, so if everybody does it, then, kind of goes out of control, and this is the situation over there as well. Blood sugar, as cholesterol, as perhaps even other factors we talk about in this session, it really doesn't cause any pain, and that's a little bit of a problem for people to realize that they have to do something about it. Like we eat a great cake and we can eat fine, and our body does whatever it needs to do to get rid of that sugar. But if we're a diabetic, we're still going to feel good eating the cake, for example. It's just that our body's not going to do as much to get rid of whatever it needs to later on. We're not going to feel any of that. And 5 years later, we may find out that there is an indolent or silent cardiovascular disease or other diseases, because all this inefficient metabolism has been going on, and we just don't know about it. And again, once this is diagnosed due to cultural and societal and peer pressure during daily life and daily meals, there is a lot of challenges to keep your priorities straight, but that's where the person needs to be very strong and apply what he needs in order to change their lifestyle, in order to figure out what non-sweet food they like, and try to avoid saying, I'm entering this, oh, I can't eat this, I can't eat that. That's very negative. They have to figure out what they like that's not sweet, and they join in and say, I want to eat X and Y and Z, that they already know that this is something that they both like and it's good for diabetes. All right? Don't make everything like a negative thing. Blood pressure is also another factor that only in extremis it creates headaches or maybe some visual diplopias and all that. Normally, you can have high blood pressure, you don't know anything about it, unless you have gone for a checkup and someone measured it, and obviously the first reaction it is, oh, it's high just here, and I go somewhere and it's fine. Well, it's fine because you really don't check it anywhere else. So again, we have to really be very vigilant and very helpful. Blood pressure has a lot to do with salt. So talk about lifestyle changes. We have to do a lot of salt reduction. No medication is going to help in blood pressure unless the person eats less salt. That has been very clear. Or let me phrase it the other way. If you eat a lot of salt, your doctor is going to be hopeless in trying to add medication after medication after medication, and you're going to label that doctor as inefficient, it didn't work, it has been on 6 medications, and this and that. On the background, you have to accept that unless the salt goes down in your regular life, and again, figure out what you like that is not so salty if you have high blood pressure. It's not so difficult. It's very complicated how to treat blood pressure. That's why we're not going to go anywhere near that. We're just going to stress the simplest factor that the person can do, limit the salt. I think it's very easy. And particularly, I must say, out of my experience with some patients with gourmet habits, Himalayan salt is extremely strong. So I promise to you that we have a couple of examples of, if you go download the ACC risk calculator, you can find out after you put, let's say, 58-year-old male, non-African American, 140, blood pressure, cholesterol 140, well, not so bad. HDL 45, again, not so bad. Systolic blood pressure 140 over 80, like a borderline blood pressure. A little bit, now it's considered hypertension. 10 years ago, it was not. It was normal measurement. Things evolve. Treated under treatment, no, because they don't know and they think it's borderline. Diabetic, yes, and smoker, no. Has a risk, 12%. I think that could be a little impressive if, everybody can see each one of them isolated. You may not exactly click on what does this mean for you? And all of a sudden, if you push the calculate button, you can actually see that your risk is 12%. To have a significant heart cardiovascular problem over the next 10 years. So again, it's you against a number that fits exactly your risk. This is another calculation for a 62-year-old female, blood pressure 145 over 100, a little bit more diastolic high blood pressure, non-diabetic this time, and again, you can see non-smoker, a risk of 4%. All right? Everybody can see their individualized risk profile. Patient management, again, is a complex thing. You can get an idea here what we see in the back end of this ACC risk calculator. There's no need to go into that at all. If uncertain of what's going on, perhaps a 4% is like, not here or there. 12%, maybe there is a little bit of a ring for you. Well, we have, as we say, imaging as a modifier in the risk. And why is imaging very important? because we heard from Dr. Barrakis that one of the most important aspects is that people don't like to get it. They don't believe that they themselves are sick, and they like to discontinue the medications because they think they don't need them anymore. Nonetheless, if you go to a doctor's office and everything else is kept the same, but in addition to the regular consultation, open the drawer or turn on a computer and they show you a picture of your own heart, of your own whatever that is, all of a sudden the person clicks that image with what the doctor says and is more likely to comply. All right, and this is the coronary artery calcium, for example, the strong family history, the measurement of the CRP, the number of inflammation, how inflamed the arteries are, a very important, had a very key publication very recently in a high-end journal, reducing our stress and controlling our stress, which is, well, welcome to America, as I say. Everybody has a lot of stress in the modern world. No question about it. We have to find ways, again, to fit it in our daily practice, how to relax and slow down. Perhaps include meditation. Whatever works for anyone, that's my answer. It's not an answer that fits anyone. Pick among many things what you like and do that thing that you like. This is a type of images that we can generate about the heart these days, very, very detailed. We can plan procedures, minimally invasive. You can see the aortic valve over here. We can just, based on that, measure it and replace it without surgery. Many things we can do these days. And working with the patients and showing the pictures, very, very important. We can even take miniature catheters, put them inside the pipe, and look at the pipe from the inside, look at the arterial wall. That's why this becomes a cross-section now. And always remember, in the end of the day, you put a small effort into the prevention efforts for your own self, you may reap a lot of benefit further down the line. This particular thing is said by Benjamin Franklin. I can recall many very similar sayings from our own church and our own culture that say exactly the same. Thank you for your attention.
Harry?
Good afternoon. I'd like to thank everyone for this opportunity. Also, to thank everyone for their friendship. I've only been here a short time, but everyone's been so helpful and friendly. I really appreciate it. I'd like to thank George Barrakis for inviting me. He's been a mentor of mine since I was a teenager, and also a thank you to the Anton family, who were also very instrumental in my upbringing. I'm going to talk about general gastroenterology today. It's going to touch on all aspects. I'm sure everyone's going to have some questions about this, especially after having the lunch we had. So I'm going to talk about a few things: colon cancer screening, reflux, bloating or fuscomata, and some constipation. So colon cancer screening is a very important thing. It's something that everyone by the age of 50 should be considering having a colonoscopy. There are other factors that may lead you to want to have it even sooner. As you can see, we'd like to start screening at 50. There'll be new recommendations coming out in the next 3 or 4 years to suggest that it should be starting at 45, not even at 50. After about age 80, we aren't doing colonoscopy screening, mostly because of risk factors of prepping and risks during the procedure. So once you're near 80, if you've had your screening, you probably can talk to your doctor and say, I'm not interested anymore. As you can see from this slide, the incidence of colon cancer starts around 45 to 50, which is why we're always asking people to get screened around that age. And as you can see, there's a higher incidence as the years go by. Now, you can intervene on that if you get your colonoscopy early and find polyps that could become cancer. So that's why we're usually stressing having a colonoscopy near age 50. These are the risk factors for developing colon cancer. A family history, if anyone in the family's had colon cancer, it's important that you get screened. It's typically 10 years before the index case saying, you know, my father had colon cancer at 60, you should get screened at 50. If your father had colon cancer at 50, you should get screened at 40. A family history of polyps, so if one person in the family had a type of polyp called an adenomatous polyp, everyone should be getting colonoscopies, and their screening protocols usually every 5 years. Polyposis syndromes are issues where there are a genetic defect that would cause people to grow polyps very quickly. All family members need screening. A personal history of colon cancer, same issue. If you had colon cancer, you'll be under an intense screening program. And then if you have inflammatory bowel disease, ulcerative colitis, Crohn's disease, the risk of colon cancer is higher, and you should be getting screening according to the guidelines. So this is how colon cancer progresses. It starts as a small polyp, and if you find these early, you actually can remove them and mitigate developing cancer. This guideline here is over about a 7 to 10 year time frame. So it doesn't happen that if you have a polyp at 50, it's going to become cancer in 2 years. This is what a polyp looks like. It's the way we remove them. But as you can see, as time goes by, the polyps get larger, the growth pattern changes to more of a malignant pattern, and then what happens is you get invasion into the wall. So the difference from here to here is a big one. Here, you can be cured even up to here, but once it's invaded into the wall, you require surgery and whatever other follow-up is needed. Other indications for colonoscopy, if there's ever blood in your stool, if you're having weight loss, change in bowel habits, abdominal pain, or if any CAT scan or x-ray suggests an abnormality, you should move on to have a colonoscopy. This is what a colonoscope looks like. It's a long tube. It has control arms. It has suction and water jet and air, so you can pretty much maneuver through the colon. This is a schematic of a polyp, and this is how we remove them. We actually put an electrocautery loop around them, and not only does it strangulate, but it also cauterizes, and then we're able to remove it through the scope. Preparation, I'm sure whoever's had colonoscopy, there's a big moan coming out. Preps are the most difficult part for a patient. It's one of the reasons they usually don't come back for a second procedure. But it's so important that you have a good prep, because if you can't see the bowel, you can't see a polyp. So it's important that preparation is good. They're working on doing newer preps. These are the older preps. Magnesium citrate, the scourge of most patients. There's a Miralax prep, which you can mix with Gatorade, tastes a little better. And then probably someone in the audience has done the Go Lightly prep. It's 4 liters of basically clam water, but it works. Now, they're working on newer preps, because the first thing every patient tells me is, can't they make a better prep that is tolerable? So I will take the prep, I'll come back. So now they're coming up with preps that are lower volume, taste better, and they work relatively quickly. They're called split preps, meaning you'll do a little bit, wait 3 or 4 hours, and do the rest of it, and it seems to work well. These are the most popular preps, and it makes for a much better procedure. Reflux is an issue that bothers a lot of people. You've seen heartburn commercials on TV. There's a number of symptoms. You can have a burning sensation, chest discomfort, people can regurgitate, cough, hoarseness, clearing of the throat. That's called a laryngeal reflux, where it actually makes it up to your upper esophagus. You don't even have to have heartburn to have those symptoms. A globus sensation, some patients have that, where they always feel like they have to swallow through something even though there's nothing there. It's actually a symptom of reflux. Metallic taste in the mouth is another common finding. So these are the typical symptoms. There are others. Your dentist may tell you that you have some enamel erosion. That's from silent reflux. You can have bad breath. You can have gurgling. You can have nausea. These are all potential symptoms of chronic reflux. Barrett's esophagus is something that everyone needs to know about. It's a change in the lining of the esophagus from chronic reflux. The thing about reflux is you don't necessarily have to feel it to have it. And Barrett's esophagus is a change in the lining from chronic reflux that's actually a precancerous change. So if you are having chronic reflux, it's important that you get a baseline endoscopy so that the doctor can look for these types of changes. So with chronic reflux, you can see acid coming up. Barrett's esophagus is actually a change where the gastric lining, which is below this circle, actually creeps up into the esophagus, and that's a precancerous change. So with our endoscope, we can go down and we can sample the area. So this is typically what happens. It can develop into cancer. So we take biopsies of this area. I can't tell with my naked eye. If I can tell with my naked eye, there's a problem, as you can see here with these nodules or with an overt cancer. But early on, we take biopsies of these erratic areas, and the pathologist will tell us whether there's something called dysplasia, which is a change. And if that's the case, then you have to be more aggressive with treatment, and there's actually a ablative therapy called radiofrequency ablation, where we can put down a probe and actually it actually burns with high frequency waves and eradicates the Barrett's esophagus. It's only indicated if you have these precancerous changes. If you have baseline Barrett's, you just simply survey it. So things you can do for reflux, George also touched upon this: weight loss, smoking cessation, having your endoscopies if you do have that. Other things that are important, again, more for general health, but also for GI health. Most importantly, if you're suffering from reflux, try to elevate the head of the bed at night and avoid lying down after eating. Those are two very important things that will help you. So everyone's seen these kind of drugs on TV or at the doctor's office. So proton pump blockers are the most potent acid blockers. They work the best. They'll suppress your acid for close to 24 hours. Usually once a day is enough. For severe reflux, we do it twice a day. The typical brands are Prilosec, Nexium, Prevacid. They're well tolerated. They're getting a bad rap. They do cause calcium malabsorption. You need gastric acid to absorb dietary calcium. When you're on these drugs, you aren't absorbing it very well. It's not 100% no, but we usually tell people who are on these drugs chronically to take calcium citrate. So if you're buying calcium at the pharmacy, you look on the label and make sure it says citrate. If it says carbonate, it's basically just dietary calcium won't get absorbed. Other issues you may have seen on TV or in the newspaper about dementia and kidney disease. It hasn't been totally proven, and we aren't really sure if that's an actual issue. Over-the-counter drugs for this type of situation, you've seen Zantac, Tums, liquid antacids. They're all good in a pinch, or if you have intermittent issues, they work very well. So gas and bloating, it's always an issue. It's one of the biggest parts of a GI practice. So these are the foods that typically can cause bloating, and I'm sure you've seen these before, but these types of vegetables are very high in gas: onions, broccoli, cauliflower. There are other issues, though, that people don't really pay attention to. So lactose intolerance. Greeks love eating cheese, they love dairy products, but there's a high incidence of lactose intolerance in the Mediterranean population. Causes a fair amount of bloating. Sorbitol ingestion, one of the hidden causes of bloating. Sugar-free gum, Orbit, Eclipse, Trident, Stride, Dentine Ice, they're all made with sorbitol or maltitol or mannitol. That's a non-absorbable sugar that's highly fermentable. Drinking excessive soda can lead to it, and then drinking with a straw leads to excessive air swallowing, which then makes you feel bloated. Everyone talks about probiotics. One of the most popular is Align. It's a bifidus strain, which is the one that's been proven to be the most beneficial to the gut. If people have a fair amount of gas, Gas-X is very helpful. I suggest the soft gels or the chewables. They work quite well, and they work relatively quickly. It doesn't fix the problem. You need to look for the problem, but it does help. So other causes of bloating: Bacterial overgrowth. For patients who have had chronic bloating, irritability, intermittent diarrhea, this is an issue that unless you look for it, you're not going to know you have it. It requires a special test called a breath test. This is where you have too many bacteria in the small intestine. You'll never know you have it unless you get tested for it. There's an antibiotic called rifaximin, which you take for 2 weeks, which will basically reset the flora in the gut, and it works quite well. Too much fructose or sucrose can be an issue. There is a fructose breath test. Lactose intolerance, we have a hydrogen breath test for lactose. So there are a number of breath tests you can do to try to figure out the issues with bloating. Irritable bowel syndrome can also be a cause of bloating. It's a number of symptoms. Celiac disease, which is an allergy to wheat, can cause bloating. You don't necessarily have to have the full-blown issues where you have wasting and diarrhea. Some patients who have celiac disease undiagnosed simply have chronic bloating, so there are blood tests for that. Probiotics are very popular and very important these days. There are a number of ways to get it. I think the best source of probiotics is yogurt. Activia has this bifidus strain, but any yogurt that you buy has a number of good probiotics. We know that they're live cultures. They work quite well. Kefir, which is a yogurt milk, is a quick way to get probiotics without having to sit and eat a whole yogurt. Pickled vegetables, kimchi, sauerkraut. Tropicana has just come out with a probiotic juice, which is pretty good. Feta and olives, believe it or not, unfortunately, they're salty, but still do have some probiotics. Constipation, another issue. What a way to end after lunch, but it is a chronic problem with patients. Definition of constipation is, as you can see, less than 3 bowel movements a week, fair amount of straining, early satiety or a sense of fullness. All of these issues come to mind. Lack of fiber or medications typically are causative effects. So these are the things that we suggest. Now, these are different. Benefiber and Metamucil are actually fibers. You mix them in water, they bulk up your stool, they keep water in the colon, they make for an easier bowel movement. Metamucil tends to be bloating. Benefiber, less bloating. Benefiber also dissolves completely. You can sprinkle it on your food. You can sprinkle it into your coffee. You can't even tell you're having it. Miralax, on the other hand, is an actual laxative, so it's a powdered laxative. The good thing about it is you can titrate the dose, and it's non-habit forming. So the problem with taking other laxatives like Senokot or Dulcolax over a lifetime can lead to problems with efficacy. They stop working after a while, and patients start complaining. So it's better to use something that isn't going to lead to that. So thank you very much. It's been a pleasure.
As they say in the military, you all have your marching orders. You heard from them. Tonight, I want to watch every one of you. So we're going to open this up for some questions. If you have any questions from the physicians, go to the microphone, identify yourself.